This podcast is not a replacement to any formal lectures or clinical placements. Hello and namaste to all. Welcome back to our podcast. I'm Anisha.
And I'm Prajwal. Here we will have discussions on different clinical cases in this case series.
Episode 4, a 10-year-old boy with fever and joint pain.
Let us start today's case discussion, Anisha.
Okay, the report reads like this. A 10-year-old boy is brought to the emergency department by his mother with the chief complaints of fever and joint pain for 3 days. The fever is of high grade and intermittent type, with the maximum recorded temperature being 102 degrees Fahrenheit. Joint pain is of migratory type, involving elbow, knee, and ankle joints mainly. These joints are red, swollen, and painful, limiting his mobility.
Can't say much. Are there any other associated symptoms?
Yes, the boy complains of chest pain, and interestingly, he has history of sore throat 2 weeks back which subsided on its own.
Okay, tell me about the examination findings.
Sure. The patient looks lethargic and irritated with fever of 101 degree Fahrenheit. Both his pulse and breathing rates are raised. Upon examination of the body, serpiginous rashes are revealed over the trunk. Friction rub is heard on auscultation.
Now, I would like to know about the lab investigation. ASO titer is assessed, right?
Yes, both the ASO titer and the throat swab culture are done. ASO titer is found raised, but the throat swab culture was negative for streptococcal infection. Additionally, blood showed raised ESR and CRP and increased leukocyte count.
Okay, it's because his sore throat has subsided that the culture was negative. Everything till now is pointing towards rheumatic fever. What do you think?
I'm also thinking about acute rheumatic fever, and the echocardiography report also favors this, which shows soft systolic murmur due to mitral regurgitation, which is very common in this disease.
Okay, since it fulfills Jones criteria with carditis, polyarthritis, and erythema marginatum among major manifestations, and fever, arthralgia, leukocytosis, and raised ESR and CRP among minor manifestations, plus raised ASO titer, the diagnosis of rheumatic fever can be confirmed.
Yes. Also, this disease is common among children and young adults between the age of 5 and 15 years in developing countries like ours. Okay, now let's discuss something about this disease.
Sure, rheumatic fever is an immunologically mediated multisystem inflammatory disease. It is triggered by an immune-mediated delayed response to infection with specific strains of group A streptococci, which have antigens that cross-react with cardiac myosin and sarcolemmal membrane proteins, and affects heart, joint, brain, and skin.
It classically occurs a few weeks after an episode of streptococcal pharyngitis. In developed countries, incidence and mortality rate of rheumatic fever and rheumatic heart disease have declined remarkably over the past century as a result of improved sanitation, rapid diagnosis and treatment of streptococcal pharyngitis. Nevertheless, in developing countries and in many crowded urban areas, it is still an important public health problem.
After an initial attack, there is increased vulnerability to reactivation of the disease with subsequent pharyngeal infection, and the same manifestations are likely to reappear with each recurrent attack. Damage to the heart valve is cumulative in this case.
It leaves permanent damage only in heart, isn't it?
Yes, you are right. It progresses to rheumatic heart disease. The turbulence of blood induced by ongoing valvular deformities leads to additional fibrosis of the valve, and the acute hemodynamic overload resulting from acute mitral regurgitation and or aortic regurgitation leads to left ventricular failure, which is the main reason for acquired morbidity and mortality in children and adolescents.
Now, let's discuss about its diagnosis, which is based upon Jones criteria. Prajwal, can you please elaborate it?
Yes, of course. The revised Jones criteria of 2015 use slightly different diagnostic criteria for low-risk areas and moderate to high-risk areas. Let me define low-risk areas first. These are those countries with an acute rheumatic fever incidence of less than 2 per 100,000 school-age children, or an all-age rheumatic heart prevalence of less than 1 per 1,000 persons. Medium to high-risk countries exceed these thresholds. Major criteria includes for low-risk areas, carditis, polyarthritis, chorea, erythema marginatum, subcutaneous nodules, and for higher risk areas, subcarditis and monoarthritis are included. Minor criteria includes fever, arthralgia, raised ESR and CRP, leukocytosis, previous rheumatic fever and first-degree atrioventricular block. Not only that, there should be supporting evidence of preceding streptococcal infection, such as recent scarlet fever, raised anti-streptolizin O, or positive throat culture. Two major or one major and two minor criteria are required in the presence of essential criteria for the diagnosis of the first episode. And for recurrence, along with them, only three minor would also work.
The list is really a long one. I would like to know, how do we diagnose carditis here? I mean, the evidences of carditis and rheumatic fever.
Okay, Anisha, in chest X-ray, we can see cardiomegaly and rarely pulmonary congestion. In ECG, there may be first-degree heart block and rarely second-degree block. There may be features of pericarditis, T-wave inversion, reduction in QRS voltage. And in echocardiography, there can be cardiac dilatation and valvular abnormalities.
Okay, now let's move on into the management. How should we manage this case?
Bed rest is a must, as it lessens joint pain and cardiac workload, the duration of which should be guided by symptoms, along with temperature, ESR, and leukocyte count. As soon as the diagnosis is made, a single dose of benzathine penicillin of 1.2 million units should be injected intramuscularly, or oral penicillin V 250 mg thrice a day should be given for 10 days.
Yeah, and if the patient is allergic to penicillin, erythromycin or cephalosporin can be used.
Yes, aspirin can be added to relieve symptoms of arthritis as well, and steroids in case of carditis or severe arthritis.
And what for chorea if the patient develops it?
It is self-limiting, but if it is severe, we can use haloperidol and carbamazepine.
Okay, these patients are susceptible to further attacks of rheumatic fever if another streptococcal infection occurs. So, to prevent this, long-term prophylaxis with penicillin is given, right?
Yes, this is called secondary prophylaxis. Benzathine penicillin 1.2 million units is given monthly or oral penicillin twice daily. For rheumatic fever without carditis, the duration of secondary prophylaxis is 5 years after the infection or until the patient is 18 years, whichever is longer. But for rheumatic fever with carditis but no residual heart disease, it should extend to 10 years or until 25 years of age, whichever is longer. And for rheumatic fever with carditis and clinically significant residual heart disease, it requires antibiotic treatment for 10 years after the latest episode, or until the patient is at least 40 to 45 years old and is sometimes continued for life.
It seems we have covered everything. Prajwal, do you want to add anything?
Sure, though it is the most common cause of acquired heart disease in childhood and adolescence, it is preventable with adequate treatment as early as possible.
And yes, widespread awareness and health-seeking behavior play important roles. Okay, with this, we have come to the end of this episode. Hope you had great time listening to us. Thank you, stay healthy, and keep learning.
Goodbye.